Next is about dementia. Now, dementia is defined as a condition characterized by progressive or persistent loss of intellectual functioning, especially with the impairment of memory and abstract thinking, and often a personality changes resulting from organic disease of the brain. Now, that's an important issue. When we speak dementia from the neurological point of view, it's a presentation presented with the organic disease of the brain. Whereas when it comes to question of psychiatric illnesses which may present with the symptoms resembling that of dementia, the difference is there is no organic involvement of the brain. You may not have a structural pathology of the brain. That's considered as psychological. But that differentiation is a very minute differentiation. And as far as the new interventions are concerned and newer information about the disease are concerned, many of so-called psychological conditions also have now proved to have some involvement of the brain, and hence that difference between a psychiatric issue and a neurological issue is very fine now, becoming thinner and thinner, and many times there could be confusion. But anyway, from our academic point of view, we will be discussing these two issues separately, psychiatric illness separately, neurological issues separately. So whatever we are discussing today, it will be limited to the neurological conditions which can present with the dementia, where there is a organic pathology of the brain tissue. This importance also has some legal issues. I will come to that part at the end of it. Now, as far as the dementia is concerned, it's one of the very common disease, and as per the WHO key facts on dementia, I have just copied it as such. Currently, more than 55 million people have dementia worldwide. It's one of the significantly increasing condition, particularly in the old age, and over 60% of them live in low and middle income countries. Every year there are nearly 10 million new cases added. Dementia results from a variety of diseases and injuries that affect the brain. Alzheimer's disease is the most common form of dementia and may contribute to 60 to 70% of the cases. Dementia is currently the 7th leading cause of death and one of the major causes of disability and dependency among older people globally. In 2019, dementia cost economies globally $1.3 trillion US. Approximately 50% of these costs are attributable to care provided by informal carers like family members and close friends who provide on an average 5 hours of care and supervision per day. This is one of the very significant issue, because dementia is not a disease which affects only one person, it affects the whole family, and the conditions or the status of the whole family could be affected by dementia. Women are disproportionately affected by dementia, both directly and indirectly. Women experience a higher disability adjusted life years and mortality due to dementia, but also provide 70% of care hours for people living with dementia. So women are prone to develop dementia, and when there is a dementia in any one of the family members, it is women who are burdened more about the care. So that's the issue. Now, dementia from organic pathology point of view are categorized into mainly Alzheimer's disease, which is the most common and important, which we will discuss in detail, as 60 to 70% of the patients are Alzheimer's. Then the other types are vascular dementia, where some cerebrovascular pathology is there because of the vascular conditions, the brain has been damaged, and then the clinical presentation would occur. We will briefly refer to that. Lewy body disease is a nomenclature of dementia produced in Parkinson's conditions. In Parkinson's, in the previous session, we have discussed about the Lewy bodies as one of the signs of the Parkinson's. In a Parkinson's disease, if the motor symptoms would occur after the psychological symptoms occur, or they occur simultaneously, that condition is called as Lewy body disease, a subvariety. There is not much of a difference, so not much of an issue as such. Then other varieties like frontotemporal dementia, alcohol-related dementia, Down syndrome and Alzheimer's disease, HIV-associated dementia, and traumatic encephalopathy, previous history of trauma-induced dementia. These are relatively less common conditions, so we will not go into much detail except alcohol-related dementia. Alcohol-related dementia is something which we will discuss somewhat in detail. Rest of the other things we can just bypass because they are not clinically so significant from the clinical point of view. Now, the most important condition is Alzheimer's disease. Alzheimer's disease is one of the very common disease condition which occurs in the old age, and it's defined as a neurodegenerative disorder marked by cognitive and behavioral impairment. Cognitive in the sense where the patient is not able to perceive or relate to the surroundings. Psychological conditions would occur, and behavioral impairment also that would occur in such conditions, and which can interfere with the social and occupational functioning of a person. History of Alzheimer's disease is quite interesting. In 1901, a German psychiatrist named Alois Alzheimer observed a patient at the Frankfurt Asylum. At that condition were treated for psychiatric issues. The patients who were considered as psychiatric illness, they were treated in asylum, and this in 1901 this patient was being treated in an asylum as a psychiatric illness, and she suffered from loss of short-term memory among other behavioral symptoms, and this was something different from the usual psychiatric illness, and this was noted by Alzheimer, and later in 1906 that patient died. He sent her brain and medical records to Munich where he was working in the lab for Emily Kraepelin, and staining, when the brain was stained and seen under the microscope, they were able to identify amyloid plaques and some changes in the nerves, and that was the beginning of identifying the psychiatric symptoms with the neurological pathology, and from that diagnosis this disease entity is named as Alzheimer's disease. So now, of course, the pathological changes due to the Alzheimer's disease is now confirmed, proved, and you have a good amount of information about what are the changes do occur as such. And even now, ultimate final confirmation of the changes would be only when you have proved that the changes are in the brain, and this would be only in autopsy after the death. So in the living conditions, this information may not be of a practical value because you may not be able to make out that microscopic changes in the brain in the living condition. It is only in the autopsy that can be confirmed. And another quite important reason, there are many people who may have, if you study the autopsy of the brain of large number of people, there are many people where the brain may show the changes which is characteristic of the Alzheimer's, but still clinically they might not have the clinical symptoms. So in the autopsy, if the brain tissue is subjected to histopathology, a large number of people may have the changes which are suggestive of the same Alzheimer's, like the neurofibrillary these plaques, amyloid plaques could be seen, but clinically they might have been normal before death, and hence it's now it's considered that Alzheimer's disease may be a slowly progressive disease where the changes may start at some other stage in the life, but the clinical presentation would occur quite later. Now, about the hypothesis, like how the Alzheimer's could occur, the exact principles or exact phenomena are not known. Certain of the hypotheses are now having weighted. Some of the hypotheses are being considered as alternative choices. Among the hypotheses, one is amyloid hypothesis and TAU. TAU is a very specific type of the protein which is present in the brain and deposition over there, and that hypothesis and genetic theory. These three, amyloid, TAU hypothesis and genetic theory, they are now established without any doubt, and they are now of practical use in identification, because TAU hypothesis it can be used as a biomarker. Assessment of the TAU protein in the serum can be considered as a biomarker for the Alzheimer's disease, and hence these three theories are now on very solid base. The other theories which are still being considered at various stages of study are cholinergic neurotransmission and theory, oxidative stress damage theory, inflammatory reactions in the brain, depression or psychiatric symptoms resulting in the Alzheimer's, or trauma, alcohol consumption are considered as the others. One of the very recent development in the this Alzheimer's theory is very important from my point of view. Alzheimer's Association of International Conference in 2023. It was presented in July 19, 2023. One of the important observation is increased levels of amyloid beta and tau in the brain. That amyloid and tau are the biomarkers of Alzheimer's disease, are directly linked to reduced gut bacteria. See, conditions of the intestines, colon and the brain, gut-brain axis is one of the new development in the Western medicine. Lots of diseases now are linked to that gut-brain axis abnormality. One of that condition where the relationship is almost proved is with the Alzheimer's disease. If the intestines are kept healthy, or if the conditions in the intestines are normal, the functions of the brain also would improve, or conditions of the brain functions, or majority of the brain functions could be affected by the status of the intestines. Now, this gut-brain axis theory is the proof that the Vatasthana is in the Pakvashaya. Pakvashaya, see, earlier there were people were joking like Pakvashaya, the intestines, and the functions of the nerves, brains. See, majority of the functions of the Vata are the neurological functions. Their relationship was not known, and it was considered to be something like a joke earlier. But now it is being proved in many conditions. It's not only in one of the conditions. Like many conditions, this relationship is being used, and at present it is related to the bacterial colonies in the intestines, colon, which is considered to be responsible for the neurological conditions. But now there is gradually the approach is changing. The condition health of the colon would be one of the means by which the diseases can be modified. With the Alzheimer's, this is a recent observation. With the Alzheimer's as such, this relationship is now being proved that there is a abnormality in the gut bacterial environment, which enhances the chances of the Alzheimer's disease. So naturally, this also gives you some scope, like when the Basti given as a treatment can produce some changes in the outcome of that disease condition. Anyway, that's about one of the other issues. Now, the basic pathological changes which occur in the brain tissue are the healthy neurons have a internal structure called as microtubules within them, and these microtubules act as tracks by which the nutrients are guided within. Now, these micronutrients may be deposited by a beta amyloid protein called TAU. TAU is that specific protein, beta amyloid protein, and it gets because of the deposition of that molecule, the microtubule gets altered in structure, which results in a impairment of the nourishment of the nerves, and this results in the collapse of the nerves, or these beta amyloid plaques could be deposited in the brain tissue, and hence the nerve tissue will be affected and the functions of the nerves are affected. The changes may be seen in many segments or many areas of the nerves. At the neurons, like as such, it may show the plaque-like appearance, and there could be a deposition of some fibrous substance over the astrocytes. That's the cells which are defending cells in the nervous system. They may be proliferated, and they will be having a more active morphology. That evidence has led to the theory that inflammatory changes in the brain could be a cause for the Alzheimer's. Then the microglia, another set of the tissues present in the nerve tissue, they too get proliferated, and they may also have active morphology. Shapes could be altered. This also is evidence that there could be some inflammatory pathology. Then in oligodendrites, that is the connecting tissues or connective tissues in the brain tissue, they may be having evidence of demyelination, and particularly in the large nerve tissue also, the myelin sheaths, the Schwann cells, they will be demyelinated, and this is a sign of degeneration occurring as such. Then the pericytes, again, another variety of the cells, they may produce a tight junction as such. They are the cells which keep the nerves in an organized manner, and their structure is altered, which can result in abnormality of the structure of the brain, and the blood-brain barrier functions also may become broken down, and this also is sign of the degeneration as such. Then the endothelial cells of the blood vessels, they also show a tight junction disruption. That's their junction would be affected, which again can affect the blood-brain barrier breakdown. So Alzheimer's disease patients, the brain may show many of these multiple changes as such, which are proved now. Now, as far as the clinical presentation is concerned, the clinical presentation of Alzheimer's is now categorized into three categories: mild, moderate, and severe. In the mild Alzheimer's disease, the initial most clinical symptom would be memory loss, and this memory loss would be again many times it will be very minute, may not be very significantly observed. Characteristically, the memory loss relates to a previous incidents. The short memory, immediate memory may not be affected. Many times the patients would find it difficult to remember the names of the persons whom they have seen earlier, or such small events may not be recollected properly. But as such, there may not be any significant changes. Otherwise, the patient may carry on his normal life otherwise, except many times he may find difficulty in finding or remembering the names of the persons or places at times, or at times he may have a confusion with the location of familiar places where he has gone regularly. He may get some confusion occasionally. And another feature which may be seen in the early mild Alzheimer's disease will be he may take much longer time than earlier to do the normal activities. So it looks like he is sluggish and slower. And the quite important would be he will be having difficulty in handling money or so on, such activities which may require some calculations, some more attention. Such activities may be difficult, but other routine activities he may continue without any trouble, so it may not be seen. But the issues may be observed. Many times these are so minute that the patient may not notice, but persons who are close to the patient, like family members, they may notice that this patient has some of these issues. And he may also have a compromised judgment. He may not be able to judge the situation properly, leading to bad decisions, and loss of spontaneity and sense of initiative. He may look like that he is not taking initiative in many of the activities. Many times these conditions may be considered as a depression, and it may be anxiety. So many times it is often misunderstood. Early stages of mild Alzheimer's are misunderstood as either depression or anxiety. In the moderate conditions, the memory loss and confusion may be enhanced, and which may become more conspicuous, and there could be attention span. The patient may not be able to give attention to any activities like hearing a speech or maybe even any activities. He may not be able to give attention properly, and the problems may be more severe, where he may fail to recognize the friends and family members. He may have a difficulty with the language, like problems with reading, writing, or numbers, and difficulty in organizing thoughts and thinking logically. So he may have a different sort of perception. So at these conditions, the personality will be changed, and the changes are very conspicuous, visible. Then he may show inability to learn new things and cope with the new unexpected situations, like he may be in a distressed condition whenever there is an unexpected reaction. Restlessness, agitation, anxiety, fearfulness, or wandering in the late afternoon at night, and this is again makes a lot of social issues where the patient may personality will be changed. Repetitive statements or movement, occasional muscle twitches also could be seen. Motor signs, maybe the beginning of the motor signs could be seen in Alzheimer's disease in such conditions. Hallucinations, delusions, suspiciousness or paranoia and irritability, which again often is confused with the psychological illness like split personality or so on. Then loss of impulse control, where the patient may have a short temper like conditions. The behavior changes could be inappropriate, or at times he may use vulgar language as such. Then perceptual motor problems. Gradually the patient may develop motor problems like fine activity. He may get trouble in getting out of a chair or setting the table. So fine day-to-day activities he may find it difficulty, and that's considered as moderate. In severe Alzheimer's disease, he cannot recognize the family or loved ones and cannot communicate effectively, and the patient would be completely dependent on others for the care, and this is one of the critical situations, and the sense of self completely is lost. Along with that, the other symptoms which may occur in severe would be weight loss, seizures also could occur, skin infections, difficulty in swallowing, moaning, grunting, increased sleeping, lack of bladder and bowel control, which makes the patient totally dependent on others, and even the hygiene around him also would be affected. Social conditions also would be affected. That would be the presentation of severe conditions. Now, to confirm the Alzheimer's, in the advanced stages it's quite easy, but early stages, early diagnosis of Alzheimer's is one of the major issues of concern now, and for this the tests, different tests are to be done. Attention and concentration tests, recent and remote memory tests, which are often used as a psychological tests, or language tests, or praxis tests, ability to perform skilled motor tasks without executive function, visuospatial functions, that's his vision and coordination with the vision, hands and eye coordination functions, they have to be tested, which are almost all the tests are in the psychiatric domain than really the physical examination domain. So psychiatric assessment sort of where you may have to use specific questions and get the answers as such. So now one of the standard model for assessment of these is called as the abbreviated mental test score or AMTS, which is actually used in the psychiatric practice. This is from the psychiatric practice, and the common test, the standard model of the test. Of course, these test questions and the model can be altered based upon the condition of the status of the patient, social conditions of the society where the patient is living, and so on, environment and so on. But this is a very standard model where all these factors, like the factors of attention, memory, language, all these are comprehensively added on, and simple questions are framed, and this is one of the standard questionnaire. What is your age? What is the time of to the nearest hour? Like now, give the patient an address and ask him to or repeat it, and at the end of the test, like give this is an example given, like 42 West Street and so on. What is the year? What is the name of the hospital or number of the residence where the patient is situated? Can the patient recognize two persons like doctor, nurse, home, etc.? What is your date of birth? In what year did World War begin? These are, I think, what I would say is there is no need to make use of the same questions. It's not absolutely necessary. But the questions could be framed in the same outline, where many of these perceptions like language and the praxis, all these could be assessed in, and his ability to correlate and his intellectual capacity, like counting backwards from 20 to 1 and so on. In this kind of a scoring, if a score of 6 or less, then it suggests of delirium or dementia, although further tests are necessary to confirm the diagnosis. That's one of the standard model of examination. Are very specific for Alzheimer's disease. There are now lots of other websites which give you the idea as such. One of the common website is Alzheimer's Association, that's GPCOG. It gives you a web questionnaire where in the website, if you log into that gpcog.com, you can get this website, and it's free. You can have a test, which now this test is aimed at even the normal persons, so that the possibility of your developing a Alzheimer's in future can be predicted. So there is a scope. It's a big test as such. So those who are interested may try this test at this website URL gpcog.com AU, it's an Australian website, where you can get the performance of your own, assess your own. With that, lots of questions. When you start with begin the test, you will have the series of questions one by one, and you have to answer. And at the end, you get a score and a possible prediction of your developing Alzheimer's is given in the form of statistics as such. Now, anyway, that's one of the methods by which the Alzheimer's is diagnosed. Now, the other method of confirmation of the diagnosis of Alzheimer's is by the imaging studies, and the imaging studies is based upon the pathological changes which occur in the brain, the morphological changes. Now, pathological, histopathological changes, they cannot be identified in a living person, it's only in the autopsy. But morphological changes which occur in the brain now are documented, and they are used in these imaging studies. The changes which occur are in the initial stages are mild to moderate changes. The cortex becomes somewhat shrunken. The folds in the cortex, they become lesser in number. Gyri and cerci becomes lesser in number. They become flatter. Now, as you see in the patient 202, the surface of the brain there is showing a similar changes there. And the hippocampus becomes shrinking. The hippocampus area of the brain becomes shrunken, and the ventricles, they tend to become dilated. Dilated ventricles would be the signs. Initially, it will be mild changes, and then as the condition aggravates or progresses, these changes become more prominent. The extreme shrinkage of the hippocampus becomes very shrunken like. Now, this is exactly what you see in that patient, MRI scan of the 202 patient, that the hippocampus has become almost shrunken. Ventricles are significantly dilated, which is again suggestive of the same changes of brain. Now, these can be objectively measured by making use of a graph in an image. If you want to have, or particularly if you want to assess the progression sequence, you can graph these images can be put on a graph, and then these can be exactly objectively measured and sequentially can be assessed as such. The other changes which can be seen, to summarize the MRI findings in Alzheimer's, either it could be hippocampal atrophy. As you see in the images like hippocampus area, there is a sign of atrophy over here. This becomes shrunken. Temporal lobe atrophy, that gradually in the next stage the temporal lobe also becomes atrophied, and the cortex becomes somewhat thinned out and becomes rough. And dilated ciliary fissure, the ciliary fissure will become dilated, and then the ventricles also will become dilated. This also, the ciliary fissure is over here, and the cortical atrophy. These are the signs. More confirmatory signs would be by PET scan. In the PET scan of normal brain, you can see more of the blood flow and more active areas. The green tissues is suggestive of more active nerve tissues, and these active nerve tissues become diminished. And in case of Alzheimer's, and PET scan is now considered as a more dependable than the MRI scan to confirm the Alzheimer's. Now, there are new development is a study of biomarkers for the Alzheimer's, where the prediction of Alzheimer's can be done even before there is a clinical presentation, and majority of these biomarkers are by assessing the cerebrospinal fluid CSF examination for either the TO protein, amyloid protein, or maybe the other abnormal contents. These tests are not yet still popular, but they are now available in very sophisticated centers. These facilities are available only in sophisticated centers, specified neurological centers like NIMHANS and so on in India. But still, other hospitals it may not be, but gradually these may become more popular, and in due course of time, these biomarkers also may become quite common investigative tools. As far as the treatment is concerned, there is no curative treatment is known till now. Lots of research is going on. There are many areas which are supposed to be promising. Among one of those areas which is promising is a transplantation of the nerve tissues, which is maybe in future it may be now one of the issues. I think in case of Parkinson's also we have referred that transplantation of the nerve tissues, and there I referred about the India being that pioneer. AAMS Delhi is the pioneer in that condition, and monkeys' nerve tissues are transplanted to human brain, and it has shown some promising results, but still it's not at as a standard treatment. The present management would be symptomatic management, which includes antidepressants, anxiolytics, and anti-Parkinson drugs like methyl-dopa, L-dopa, and beta blockers, epileptic drugs, and neuroleptics, which stimulate the nerves. But none of them have a curative benefit. But more dependable would be a mental activity support. See, patients who have a tendency to have these Alzheimer's, and if they are identified at the early stage, progression from the mild to moderate can be effectively reduced, or it can effectively slowed down by giving regular mental activity exercises like maybe some puzzles, these word games, like they help in reducing the progression. And one of the very dependable and almost sure remedy is the practice of pranayama and yoga exercises. They help in reducing, maybe slowing down the progression significantly. Then dietary measures and physical activity also are now given a lot of importance. Diet, like where there will be more of fruits intake, and regular physical activity are also considered to be one of the better tools. So they are more dependable. Then certain of the drugs which are now recently introduced, or which are recently developed and recently introduced, some are available in some centers, and they are also now being prescribed in India also. Many of the patients of Alzheimer's may have these prescriptions which we have seen, but what I have found is the benefit of these medicines is not so conspicuous or not so dependable as that of the mental activity support or the physical activity like yoga and the pranayama. But anyway, those drugs which are now being used are cholinesterase inhibitor drugs like donepezil and rivastigmine. These are now prescribed in many centers. Anti-amyloid beta monoclonal antibodies now also are available, and they are quite costly. Many of the patients also are prescribed these drugs as such. The other experimental therapies which are now being trained or tried at different levels of research are vaccination with the amyloid species, then administration of monoclonal anti-amyloid antibodies, administration of intravenous immune globulin, selective amyloid lowering agents, chelating agents to prevent amyloid polymerization, brain shunting, surgical treatment, brain shunting to improve the removal of amyloid, and beta secretase inhibitors. These are the drugs and the techniques which are now in different stages of trial. Maybe in future some of these may become a regular prescriptions. As far as my clinical experience is concerned, I would be treating a patient of Alzheimer's disease with the Sumsagara Kamadaga Sarasravista, Tailadhara and Ratyapanabasti. Pranayama and yoga asanas are trained, by which we can produce a pronounced slowing down of the changes. I don't say that the patient would recover, but the whole issues can become slowed down. Many of the physical activities, basic physical activities may be gained by the patient, and the quality of the life would improve with this treatment. That's about Alzheimer's. The next is about the vascular dementia. Vascular dementia is not a single disease. It's a group of syndromes relating to different vascular mechanisms like atherosclerosis and so on. This term was used as a specific dementia, vascular dementia, from 1985 onwards. Earlier, the term used was senile dementia. So still, when I write this diagnosis, still I usually write senile dementia as the diagnosis. But now, as per the nomenclature, international nomenclature from 1985 onwards, a broader term of vascular dementia is used for the diagnosis of these conditions. The types of the vascular changes which can present with the dementia are now considered to be infarctions, brain infarctions, complete infarctions, cortical or subcortical, in 75% of the patients. Lacunar infarcts will be in 50%, or microinfarcts in about 50%, cystic infarcts in about 25%, hemorrhoid angiopathy is in 10%, intracerebral hemorrhages in 2%, hippocampal atrophy and sclerosis in about 55% produced due to the ischemia. Now, these, of course, these percentages are not important. Many of the, almost every patient of cerebrovascular accident who has the infarctions developing has a high possibility of developing a dementia also. That's the important issue. I think that would be enough as such. Now, to make out the difference between Alzheimer's and vascular dementia, there is a standard method of Hashinsky ischemic score which makes out the differences by clinical examination as well as the investigations. Clinical examination and history point of view, if the symptoms are onset, abrupt onsets, and they have a fluctuating course, the score will be 2 each. The personality is preserved, score will be 1. Somatic complaints like body aches, chest pain, 1. History of or presence of hypertension is 1. Evidence of coexisting atherosclerosis like peripheral arterial disease, myocardial infarction, 1. Focal neurological signs like paralysis, what we see, many of the patients have paralysis, Babinski sign, again the score will be 2. Stepwise deterioration, gradual, is score 1. Nocturnal confusion, more at the night, depression, emotional stability, history of stroke, again each of them would be score 1. And neurological symptoms like paralysis, hemianopia, aphasia, again the score will be 2. Now, if the total score is 4 and the patient has a dementia, it could be diagnosis of Alzheimer's disease. If the score is more than 7, that is evidence of vascular dementia. So, to make out whether it's a vascular pathology or Alzheimer's disease, this Hashinsky's ischemic score is used as a standard. If the score is in between 4 to 7, it's indeterminate where you have to depend upon the other signs. Now, if you go into the neurological textbooks, you will find lots of subtypes of vascular dementia like vascular cognitive impairment, multi-infarct dementia, vascular dementia due to strategic single infarct, vascular dementia due to lacunar lesions, vascular dementia due to hemorrhagic lesions, Binswanger disease, subcortical vascular dementia, mixed dementia. But all these differences are of very little practical clinical use. These are only academic exercise. Ultimately, when it comes to the question of treatment also, the differences are not much. So make it simpler. Instead of going to all these 8 varieties, and it's only the issue of nomenclature and accurately specifying the location of the lesion, not much of a issue. So I will make it brief instead of going to that complicated issue. The simpler classification which was done earlier is also simply cortical and subcortical. If the cortical ischemia, the ischemia occurs in the cortical area, its symptoms will be predominantly cognitive related to the environment, questioning, behavior, personality, etc. Whereas the subcortical, there will be predominantly motor signs. The patient may have difficulty in moving, handling, and so on. So that's how it is better classified. These radiological evidences are exactly the same as in case of any cerebrovascular accident. Chances of patient developing dementia would be more if the angular gyrus is involved, because that's the area where the intellectual activities are controlled more. or if the thalamic infarct, if the infarction in the thalamus area, there again the chances of the patient developing personality changes and dementia would be more. So patients of cerebrovascular accident, when we see the MRI scan, we can predict whether this patient may have a dementia in due course of time or not. And based upon this, the thalamic angular gyrus infarct, thalamic infarcts, and temporoparietal infarcts. These are the conditions where the chances of dementia or personality changes may occur more frequently, and that's what we can predict, of course. As far as the outcome is concerned, there is no specific curative treatment for this condition. All the treatment protocol of Pakshaghata can be used as such. From the contemporary science point of view also, there is absolutely no specific curative treatment. All the treatment would be symptomatic treatment and the basic treatment of the cerebrovascular accidents. As far as the protocols of the treatment of cerebrovascular accidents, we have already discussed. So that's about the major dementia issues. The other finer varieties we will not go into much. The Lewy body disease as such is no way different from Parkinson's disease. The only issue is about the onset of the clinical presentation. If the onset of dementia is before the development of the other symptoms of Parkinson's or simultaneously, that's called as Lewy bodies. Now, one of the other sensitive issue when you treat the patients of dementia would be the legal issues. In India, the recently introduced Act, Mental Health Care Act of 2017 regulates the care of patients with psychiatric illness, mental illness. Now, whether dementia is an organic pathology, whether comes under the mental domain or whether it is a neurological domain, is not clarified as such. But any patient who has an inability to have a judgment, behavior, capacity to recognize reality or ability to meet the ordinary demands of life, they are now categorized as mental diseases from the legal point of view. Now, that's an important issue. The definition of mental disease from the point of view of our law, the Mental Health Care Act is any patient having a substantial disorder of thinking, mood and perception, orientation, memory, judgment, behavior, capacity to recognize the reality or ability, and it doesn't regard mental retardation as a condition of this mental illness. Anyway, that's not the important issue. From the current point of view is this: to consider whether these patients have to be under the psychiatric domain or neurological domain, medical domain, is the issue which is not yet very clear cut. But as far as the treatment is concerned, of course, from the Mental Health Act point of view, the mental health professional is a person who is authorized to treat such mental conditions, are a psychiatrist or a professional registered with the concerned state authority under section 55. That's not the general practitioners as the psychiatric doctors. Professional having a postgraduate degree of Ayurveda in Manovijnana evam Manasa Roga or postgraduate degree in homeopathy psychiatry, they are the only ones who are authorized to treat the patients of mental disorders. But dementia is under neurological condition which can be treated by the physicians, any physicians rather. So that is the issue. And moreover, the issue comes in when it comes to the question of certification and so on. When a patient, even you have to, in the medical profession, you may have to give certificate for many situations. Particularly in the patients of dementia, if you have to give a certificate related to his ability to perceive or judgment and so on, which has a lot of legal issues like power of attorney or ownership and so on, you have to be extra careful. A general practitioner may not give certificate from that point of view. But certification from the other point of view, like a physical illness, like the patient is not able to move, patient cannot sign and so on, that kind of a certification can be given. So that's another of the sensitive issue. With this we conclude today. We will continue in the next session about the other psychiatric illness which may mimic this mental issue, and the psychosomatic diseases where the neurological involvement also is there. With this we conclude today. If there are any questions, I think we'll try to answer. Ayurvedic treatment continue to see there is no question of limitation to the duration, because it's a condition which is not curable. As long as the patient lives, you may have to continue the treatment as such. There is no question of complete cure, so you cannot specify the duration also. Yeah, right. Okay. That no more questions, so we'll wind up.